Good morning. My name is Dr. Prabhu CS. I am the professor of the Department of Radiology, Sri Lakshminarayan Institute of Medical Sciences. Today, I am going to talk about basic first trimester ultrasound. Before we go into the basics, we should be very clear about the terms that we are using. So, what is a embryo and what is a fetus? As you can see on the left side, you can see a cylindrical structure, but we cannot able to make out which is the head end, which is the foot end, where is the heart. All those things is very difficult to assess in this picture. There is a big sac within which the structure is there, and there is another rounded structure. This is nothing but the yolk sac. Now, an embryo is the structure before 10 weeks of gestational age. And if you look at the image on the right side, you can see a fetus with clear-cut organs. You can see the head, you can see the nose, the lips, the chin, the thoracic area, the abdomen, the buttock area, and the limbs probably were seen in a different plane. So fetus is the term that we are using for post 10 week scans, gestational age scans. So this is a scan when the organogenesis is complete and the fetal growth and organ maturation ensues after that. It will just get bigger and bigger, and there will not be any new parts that are being formed. But in an embryo, it is not the case, where the differentiation between structures are not very clear. When to perform the first trimester scan? Ideally speaking, it is advisable for the first trimester scan to be done between the 11th and 13 weeks, 6 days gestation. And this is a grade A recommendation by the International Society of Ultrasound of Obstetric and Gynecology, ISWAG. That is because during this time, the complete organogenesis is complete, and we can rule out major anomalies that can be seen during this time. A scan during the 6th week or the 7th week, we can assess the viability, but we cannot assess whether there is any malformations or not. So that makes unwanted ultrasounds and unwanted spending for the patient. But we all know that scans are done much earlier, maybe around 7 weeks, 8 weeks, 9 weeks, 10 weeks. This is to confirm few things. To confirm whether the pregnancy is intrauterine or an ectopic. And there are various other reasons which we can see here. Viability is something that we always look for, whether the pregnancy is viable or not. That means whether the fetus that has formed or the embryo that has formed will grow in the future is viability, So that is one sign that to look for is to look at the heart rate. So if the heart rate is there, it is a viable fetus. Obviously, we are not ruling out any major anomalies. We're just telling whether it is a viable fetus or not. And the other point is the location. As I told you, whether the pregnancy is intrauterine or extrauterine, like ectopic pregnancies. Next is to establish the gestational age accurately. So measuring the crown rump length is accurate in the first trimester. So whatever be the measurement and whatever be the corresponding gestational age will be most accurate in the first trimester. And that is called as the dating scan, which will form the baseline for future scans. Hence, it is very necessary or very essential for us to have a first trimester scan. The time is debatable as we spoke earlier. It is also useful for us to determine the number of fetuses, whether there is a single pregnancy or a twin or a triplet. And in case of a previously complicated pregnancy like abortion or fetal anomalies, and earlier scans to confirm a viable fetus will relieve a lot of apprehension for the couple and for the doctor as well. The other thing is look for gynecological pathologies like septate uterus, uniconjugate uterus, and any other uterine anomalies, any other uterine lesions like fibroid, which can complicate pregnancy at a later date. Can also be used for look at any ovarian lesions or functional cysts, which can complicate during pregnancy. So these things has to be documented. Coming to the purpose of the first trimester ultrasound, as I told you, it's looking at confirming the viability. Now, when I'm talking about a first trimester fetal ultrasound scan, I'm talking about the 11th to the 13-week 6-day scan. If there was a previous scan done, the 11th to 13-week 6 days scan, the FTS, first trimester screening scan, can be used to confirm the viability. It can be used to confirm normal interval growth, or if it is done for the first time, whether it is appropriate for the gestational age, or it can be used as the dating scan to ascertain the proper gestational age. The next thing is to confirm the number of fetuses and the viable fetuses. So in the first trimester, earlier scans, we would have seen 2 fetuses. But during the first trimester screening at around 12 weeks or 13 weeks, sometimes we might see one fetus developing better and the other fetus might not develop, and the other fetus might just die. The fetus might not have a good heart rate, or the fetus might be very small. Now that becomes a unviable fetus, and the fetus that is growing normally is a viable fetus. So that is very useful for the FTS scan. The next thing is the major thing that we always do the scan for. Otherwise, the FTS, the first trimester screening scan, is otherwise called as the Nuchal translucency scan, NT scan. That is helpful for us to rule out major chromosomal abnormalities, to look for nasal bone, to look for gross fetal abnormalities like acrania, gastroschisis, omphalocele, any absent limbs, etc. can also be looked at the first trimester. As I told you, most of the organogenesis is complete by then. Other things like ductus venous flow and tricuspid flow can also be assessed, which are markers for major anomalies and can guide the clinician and the couple on how to progress with the pregnancy. We should also note that many gross malformations may develop later in pregnancy, or sometimes it may not be even detected, even with the most appropriate equipment and the most experienced hands. So, how to avoid these things? To have a good practice. Now, good practice guidelines is given by ISWAG. And on that, we should also be knowing about the local regulations. So in India, we have the PCPNDT Act, which is a very strict act, which has to be followed by the radiologist or the person who's conducting the ultrasound, for which we'll have to collect few things. It's a must, it's a mandatory thing. We should all know about it. So first of all, in the scan center, we should have appropriate boards in the local language and in English. It should have the instructions to the patient and what the scan center will be do. This will be provided by the government itself. It varies from state to state, and it varies from state to state. As I said, the color of the board and the content of the board may vary from state to state. That is a must. It should be there. It should be projected to the public in the waiting area. The other thing is we should know about Form F. Now, Form F is something where the demography of the patient is entered along with the RCH ID of the patient and the Aadhaar card details as well. And another form, the Form G or the consent form in the local language, has to be also collected from everyone. These documents should be stored locally and to be given to the corresponding authority in accordance with the local protocol. The other good practice thing is to have a specialized training that is appropriate for the practice of diagnostic ultrasound for pregnant women. Not everybody can do a complete analysis of fetal screening. It is not very easy. It is a skill which will come only for persons who have a specialized training. The other good practice is to counsel the woman or the couple about the potential benefits and disadvantages of the first trimester ultrasound scan. We should make sure that the patients and the couple understand the importance of the scan and also the limitations of the scan. It is not that a normal scan will be a normal pregnancy. Sometimes a normal scan might have some abnormality in the later date. So we should counsel the couple regarding the limitations of the study. But the advantages of the study also has to be explained so that they will go ahead with the scan. What are the other good practices is fetal exposure times should be minimized according to the Alara principle, as low as possible principle. The other things is to have shorter scan times possible, lowest possible power output needed to obtain diagnostic information, least exposure to sensitive tissues like heart. So these are a good practice guidelines on the ultrasound machine. It has been well proved that both B mode, which is just the normal grayscale ultrasound, and the M mode, which is otherwise called as the movement mode, which is like a superimposed mode on the B mode, where the movement of any structure within it will be displaced as lines. This is called as M mode. So these two things are very, very safe at all stages of pregnancy. But we should also know that Doppler, where the focus is on a very focal area, the amount of energy given to that area is more, and hence sensitive tissues might get heated up or can cause some cavitation, even though there is no documented data on this. Theoretically, it might cause some heating and cavitation. Hence, Doppler examination should be only used in the first trimester if clinically indicated. The other thing is equipment that we should know. We should have a really good machine with real-time grayscale ultrasound. We can either use transabdominal and transvaginal ultrasound transducers. We should have an adjustable acoustic power output controls with output display standards. We should have freeze frame and zoom capabilities, electronic calipers, and regular maintaining and servicing with adequate calibration. All these things are must to have an optimal image, because a suboptimal image might not give correct values, which might hinder the report and the result of the study. The choice of taking a curvilinear probe or a linear probe or a transvaginal probe or a 3D probe is left to the person who's doing the ultrasound. There are no strict rules, but if someone is comfortable with any probe, they can go ahead and do it. The disadvantages being a linear probe does not have a good penetration level, but the quality of images might be very high and can be used in a very thin patient. What are the guidelines for general examination? So once the mother comes to us, we do the counseling, we tell them the advantages and the disadvantages, we put the patient on bed, and what are the things that we are going to look at? So we are going to look at the viability, the first and foremost thing. We are going to check whether the heart rate is there or not. We're going to confirm the location, whether it's an intrauterine or extrauterine pregnancy. Then make some measurements to assess the gestational age. We're going to look at the assessment of fetal anatomy. And then we're going to look at chromosomal abnormality assessment. We are also going to look at other intrauterine and extrauterine structures. As I told you, the first and foremost thing is to look for viability. In general, the viability term means to live independently outside the uterus. But strictly speaking, a 10-week-old fetus or 11-week-old fetus cannot survive in the outside world. So, in respect to ultrasound and in respect to the first trimester screening, viability means confirms the presence of an embryo with cardiac activity at the time of examination. That is what it implies. So if we have a fetus with a heart rate, it is a viable fetus. Location, as I told you, very, very important to assess whether the gestation is intrauterine or it is ectopic, because ectopic pregnancy needs to be treated as soon as possible to avoid major complications. But when do we call a pregnancy an intrauterine pregnancy, or when do we use the word intrauterine gestational sac? It's very important. Now, here you have an image on the left side, which is showing an anechoic cystic lesion within the uterus. Yes, this is an intrauterine cystic or an intrauterine sac, but it does not have any fetal pole, or it does not have any yolk sac, or does not show anything. So what is this? So there are three things that can have a similar appearance. So one is a gestational sac without an embryo which has not yet formed, a pseudo-gestational sac which is seen in ectopic pregnancies, or this could be an anembryonic pregnancy. So how to confirm this, and what is the terminology to be used? We'll come to that. Okay. On the right side, you see a sac with a fetal pole. Now this is definitely an intrauterine gestational sac. Now, the image on the left, we can call it a sac without a fetal pole and follow it up after 15 days to assess for the appearance of a fetal pole. If the fetal pole doesn't come, it becomes an anembryonic pregnancy. If we find another sac elsewhere in the pelvis or elsewhere, it becomes a pseudo-gestational sac. Or if the fetus comes, then we can label it as the intrauterine gestational sac corresponding to whatever age it comes. Measurements and assessment of fetal age. Now this is the most common thing that we all will do. We can do this measurement of the crown rump length either transabdominally or transvaginally, for which certain rules are practiced or should be followed. We should make sure that the fetus lies in a horizontal position with the head facing the probe. We should have a midline sagittal section, and the image should be magnified sufficiently to fill up most of the width of the ultrasound screen. It should be quite a big image. Also, the fetus should be in a neutral position where we can see fluid between the fetal chin and the fetal chest. There is some amount of fluid. And the endpoints, that is the crown and the rump length, should be clearly defined. These are proper rules to take the CRL. The next thing is to take the biparietal diameter and the head circumference. This is usually done at the level of the thalamus or the transthalamic plane. At an earlier date, we might not see the thalamus. We might just see lateral ventricles with choroid plexus. We can take that plane as well. We should also make sure that there is a true symmetrical axial view of the fetal head, and we should not put a lot of pressure on the abdomen so that the fetal head distorts and might give us erroneous values. The correct axial orientation is when you see both the anterior horns and the low occipital lobes, which is a plane above the cerebellum. We should not see the cerebellum in the BPD plane. Next, going to the general assessment of the fetus, where we are screening the fetal anatomy. So from head to toe, we have to screen the following structures. In the fetal head, we should first of all, we should know whether the fetal head is present or not. Then we should look at the fetal cranial bones, which should be ossified by that time. We should have a midline falx cerebri, which is in the interhemispheric fissure region. We should see lateral ventricles, which is filled with choroid plexus and is echogenic. And at a later date, we can see the thalamus on either side of the interhemispheric fixture, and along with the tentorium, it forms an arrow sign. These are three structures we should be looking at. These are the few structures we should be looking at in the fetal head in the first trimester screening. In the face, we are supposed to see few things. We are supposed to see the nasal bone. We have to see the eyes with the lens in between, and the eyes should be of the same size and within the orbits. There should not be any proptosis. If possible, we should also see the fetal face in an end face view, where you can see the lips and the nose. We can identify cleft lip in some of the patients. It's tricky, requires expertise, but we can do it. The other thing that we have to see is the neck region. In the neck region, we have to use a mid-sagittal plane like the one shown in this image, where you will see the nasal bone anteriorly, the nasal tip. We must be having the diencephalon, which is somewhat hypoechoic in the middle, and the nuchal translucency or the nuchal membrane, the posterior most structure. So these are the things that we have to see in the fetal face, head, and neck. We'll go to the fetal thorax. In the fetal thorax, we should make sure that the fetal heart is in the correct direction, or the axis of the heart is oriented properly. We should know that the heart usually occupies majority of the thorax, approximately 2/3. We should also know that the bilateral lung fields must be homogeneous and it should be symmetrical. There should be no effusion. And in the first trimester, usually the chambers are of symmetrical size. The next thing is going downwards, going into the abdomen. We should also see the stomach bubble. If the fetus is head down, that is cephalic, then the stomach will be at 1 o'clock position in relationship to the vertebral body. If the fetus is head up, then the stomach bubble will be at 1 o'clock position in 11 o'clock position in relationship to the vertebral body. We should also see the two kidneys on either side of the vertebra here, with the renal pelvis here, black, and also see the bladder. Going to the fetal spine, which is one of the most important things that we have to concentrate on in two planes. We have to not only take it in the longitudinal plane, we also have to take it in the axial plane with an intact overlying skin. So this is the vertebra here you are seeing. This is the cervical vertebra, thoracic, lumbar, sacral, and coccyx. And you can see that the complete vertebra is covered with skin. This is the nuchal translucency, or the nuchal membrane here. We should make sure that the skin is intact throughout. Then we have to concentrate on the abdominal wall anteriorly. We have to make that the umbilical cord inserts normally in the midline of the stomach. There should not be any umbilical defects. We should also make sure that the extremities have 3 segments. Both extremities will have 3 segments. If you look at the lower limb, it has a thigh, the leg, and the foot. And the upper limb will have the arm, forearm, and the hand. We have to make sure that all these structures are well formed. The most important thing is to look for chromosomal abnormality assessment. Where we will be using multiple parameters, but the most important parameter is the nuchal translucency thickness measurement. The other things that are used are the measurement of free beta or total HCG, pregnancy associated plasma protein A, nasal bone, tricuspid regurgitation, and ductal regurgitation. So with all these things, there will be a risk factor that is assigned to every mother. Measurement of the nuchal translucency has to be done in a particular plane, and there are certain rules to be followed. If you look at the image here, this is more or less similar to the CRL image, but the only difference is it is being zoomed up very nicely, and you can see only the head, the neck, and the upper portion of the thorax. So the whole screen should be filled up with this image only. After this, we have to get a plane which is in the exact mid-sagittal plane. As I told you, the anterior part of this will be the nasal tip here, the translucent diencephalon, and the posteriorly the nuchal membrane. And the nuchal translucency thickness is the distance between the nuchal membrane and the soft tissue that is covering the cervical region. We should also make sure that the amnion is seen separately posteriorly. We should not confuse with that. The calipers should be placed between the nuchal membrane and the soft tissue covering the cervical area, and it should be crossed from inner to inner diameter or the length. The other things that I was talking about is the nasal bone, which is a soft marker for aneuploidies. We should also look at the ductus venous flow in a slightly parasagittal position, which is a vessel which connects the umbilical vein to the IVC. And it shows a typical waveform which has the S, D, and A wave, where the S wave indicates the systole of the ventricle, D, the diastole of the ventricle, and A wave, the atrial systole. Now, we should notice that in the image here, that all these waves are above the baseline. This is a normal value. The next thing is to look at the tricuspid waveform. This has to be taken in the axial plane, and keep it at the right atrioventricular junction, and we'll get a normal waveform where the velocities are within normal limits. As I was telling, we should also look at other intra and extrauterine structures. We should look at 3-vessel cord, because a 2-vessel cord where there is only one artery and one vein is a soft marker for abnormalities. Sometimes it's an incidental finding. We can see the umbilical cord at 2 levels, whether the free floating umbilical cord like the image B, where you can see one artery and two arteries and one vein, or we can see at the level of the bladder where the 2 arteries will wind round the margins of the bladder. The other extrauterine structures that we'll be looking at is the placental location and texture. We should always see the placenta, the location of it, and the inferior margin of the placenta we have to trace, which is very easy to trace in the first trimester. We have to measure the distance between that and the internal cervical os. This is of utmost importance because we might come across placenta previa where the internal os will be covered with placenta, and the degree of placenta previa can vary. Usually, a low-lying placenta will cranially migrate as the pregnancy progresses, but a placenta previa might not. So that might give a hindrance for normal delivery, and we have to plan for cesarean appropriately. The other thing that we have to mention is the cervical length or the cervical anatomy, where a reduced length shows an increased risk of pregnancy loss. These are the structures and the things that we should be looking for in the first trimester screening. We should also look for the adnexa to look for any ovarian pathologies. As I said, sometimes like you might have some ovarian dermoid, or you might have even an ovarian malignancy as well. Cysts up to 6 centimeters has to be mentioned. Up to 3 centimeters is nothing but a functional cyst. But anything above that has to be mentioned in the report and followed up on a close basis. A typical first trimester scan report must have the following details in it. As you can see here, there is a single gestational sac with a single fetus in it. So that signifies it's an intrauterine gestation. Cardiac pulsations are seen, so viability is confirmed. They have also spoken about the placenta position, whether the internal os and cervical canal are closed. We have to mention the distance between the inferior margin and the internal os if it is low lying. We should also talk about presence of retroplacental hemorrhage or subchorionic hematoma, because that might complicate pregnancy at a later date. We should measure the nuchal translucency. We can see that the nasal bone is visualized or not. Some studies say we should measure it. Some studies say if it is seen, it is good, because a hypoplastic nasal bone is again a soft marker. We have to do the ductus venous scan, which should show a normal waveform. We should also rule out tricuspid regurgitation. We should see whether the stomach bubble is seen or not. We should look at or fold limbs. We should look at the spine. And in the head, we should be able to make out the midline falx and the echogenic cerebellum. If done at a later date around 13 weeks, then we can see the thalami as well. We can also do an uterine artery screening Doppler, which is being followed nowadays. And the PA has to be measured. Now, this is an indicator for development of preeclampsia at a later date. Studies have shown that adding that to your first trimester screening will add value to the patient's management. All these points has been taken from the ISWAC guidelines, which is available freely on the internet, and it is very well laid out in this PDF format. If you have time, please go through it. It gives you a picture on how to do things and what not to do. With this, I would like to end my talk. Thank you very much for listening.